Hello everyone, I'm gonna present my research study predicting QT interval prolongation in patients diagnosed with the 2019 coronavirus infection. Here is a little bit background. COVID-19 patients frequently develop QT prolongation that can cause torsades de pointes and sudden cardiac death. The T-still score is a cumulative score to predict the risk of QT prolongation. Experts from the American College of Cardiology in the early phase of pandemic recommended continuous cardiac monitoring in patients with a T-still score equal more than 7. According to this recommendation, we received an email back then regarding to how to select patients who may benefit from cardiac telemetry. Every patient admitted should have a baseline EKG if they are on erythromycin and hydroxychloroquine. Every patient should have a T-still risk score calculated. If the score is 6 or less, they do not need to be on telemetry. If the score is 7 or more, those patients should be on tele in order to monitor QT interval. Here, this table shows the T-still score. It's based on 10 risk factors, including age, female sex, loop diuretics, serum potassium equal or less than 3.5, admission QTC equal more than 450 milliseconds, admitted for acute MI, sepsis, congestive heart failure, and also the number of QT prolonging medications. The maximal risk score is 21. If the score is equal or less than 6, those patients are considered low risk. 7 to 10, patients are considered to moderate risk, and equal or more than 11, those patients are considered high risk. Looking closely at this recommendation, I realized that this is only based on experts' opinion instead of evidence. The T-still score was initially developed from the critically ill patients admitted to the cardiac critical care unit. My hypothesis is that generalization of the performance of the T-still score in the critically ill patients with severe underlying heart conditions to COVID-19 patients may overestimate the risk of QT prolongation. Here are my research questions. First, what is the incidence of new onset QT prolongation in COVID-19 patients admitted to a non-ICU setting? How well does the T-still score stratify COVID-19 patients based on their risk to develop QT prolongation? If the performance of the T-still score is not ideal, what are the major risk factors for developing new onset of QT prolongation? This is a retrospective study. We include adults with confirmed COVID-19. The corrected QTC less than 500 milliseconds on admission, and patients had to have at least one follow-up EKG during their hospitalization. Patients who were admitted to a non-ICU setting. We exclude those patients with QTC on admission equal more than 500 milliseconds, and also those patients who admitted to ICU because those patients were automatically put on cardiac telemetry. We also exclude patients with no follow-up EKG or if the patients were discharged from the emergency room. Our definition for QT prolongation is a QTC equal more than 500 milliseconds or an increase in QTC equal more than 60 milliseconds compared to the baseline QTC. We manually calculate the QTC using two formulas depending on whether patient has a left bundle branch block or paced rhythm. We used receiver operating characteristic curves and the area under the curve to assess the performance of the T-still score. We also use univariable analysis to identify the potential variables that enter a multivariable model. And finally, we use logistic regression model to identify the major risk factors for QT prolongation. Going to the results section, this is the baseline characteristics of 178 COVID-19 patients. The mean age is 63.5, 52% were males and 48% were females. 76% were black and the average length of stay is 149 hours. The mortality incidence in the early phase of pandemic in our hospital is 13.5%. And as we expect from Detroit population, most of our cohort have multiple comorbidities. 76% of patients, when they are admitted, they have sepsis, and 36% of our cohort develop AKI during hospitalization. The majority of patients received azithromycin and hydroxychloroquine, and the average number of QT prolonging medications per patient is 2.3. The admission QTC is 447 milliseconds, and the peak QTC during hospitalization is 463 milliseconds. And the incidence of QT prolongation in the hospital is 11.8%. This answers our first research question. The mean T-cell score is 10.6. That means the majority of patients will have a T-cell score higher than the cutoff of 7. We used the ROC curve to assess the performance of a T-cell score in the COVID-19 patients. The x-axis is 1 minus specificity, and the y-axis is the sensitivity. The dashed line here shows the test with no predictive ability, and the T-cell score has the AUC of 0.6. Any test below 0.7 is considered a poor test. Speaking in another way, 91.6% of our cohort had a T-cell score of equal or more than 7, and if you use 7 as the cutoff, you have a sensitivity of 85.7%, but a very poor specificity of 7.6%. The take-home message for this graph is that the T-cell score is not a good score to stratify COVID-19 patients. We also used the univariable analysis to identify the potential risk factors for QT prolongation. The variables marked as red reach the statistical significance, and those variables will be put into multivariable logistic regression model. And this is multivariable analysis, and this graph is forest plot, and the dot represents odds ratio. And as we can see, patients with history of ESRD, the QTC equal more than 450 milliseconds on admission, or potassium equal or less than 3.5 are at a higher risk of developing QT prolongation in the hospital. Here are conclusions from our study. The T-cell score is not a useful tool to stratify hospitalized non-critical COVID-19 patients based on their risks of developing QT prolongation. Clinicians may consider initiating continuous cardiac monitoring for patients who present with a history of ESRD, QTC equal more than 450 milliseconds on admission, or serum potassium equal or less than 3.5. Of course, a study has limitation. First, this is a retrospective study involving a limited number of COVID-19 patients. EKGs were also not performed regularly and vary significantly between individual patients. And lastly, QT prolongation is not equal to torsades de pointes or mortality from cardiac arrhythmia. Thank you.